I am Bernard Herschel. Before my retirement, I was the chief of HIV/AIDS at the Geneva University Hospital. You might call me an AIDS dinosaur who has followed the HIV epidemic from the very first cases in the early 1980s through the triumph of antiretroviral therapies unequaled in the annals of medicine. Of course, this triumph has its flip side. Younger colleagues are no longer familiar with the opportunistic diseases and their myriad manifestations. Hence, the idea of these videos. After a short introduction, they will feature a series of images illustrating one or several exemplary cases from my files. Bacterial pneumonia used to be as frequent, although less specific than pneumocystis pneumonia. It is AIDS defining if there are 2 or more episodes within 24 months. Streptococcus pneumonia is the etiologic agent in 2/3 of cases, but there are many other possibilities, for instance Haemophilus, Legionella, Rhodococcus, and others. Bacterial pneumonia used to be as frequent, although less specific for HIV infection than pneumocystis pneumonia. It is considered AIDS defining if there are 2 or more episodes within 24 months. 2/3 of cases are due to Streptococcus pneumonia, but other etiologies are possible: Haemophilus, Legionella, Rhodococcus equi, etc. The radiology varies. Contrary to HIV-negative persons with pneumococcal pneumonia, only a minority of patients have typical alveolar lobar infiltrates. The infiltrates may be diffuse reticulonodular or focal or even cavitary. Often the radiologic appearance is atypical for bacterial pneumonia. Diffuse reticulonodular infiltrates are as frequent as alveolar segmental or lobar infiltrates. I remember this patient well because he was admitted to the ER directly from his own wedding, staged to quote-unquote prove that he was not homosexual. Blood cultures yielded Streptococcus pneumoniae. He recovered but was readmitted 3 months later, again with lobar pneumonia due to pneumococcus and with positive blood cultures. Note the infiltrates with a metapneumonic effusion arrow. Case 2 presented again with pneumococcal pneumonia, but the chest X-ray is less typical. He had fever and rigors, he was moderately immune suppressed, sputum and blood cultures yielded Streptococcus pneumonia, but in contrast to case 1, there is a diffuse reticulonodular infiltrate in addition to hilar adenopathy. Next is a case of Rhodococcus equi pneumonia in a 37-year-old jockey with HIV infection and a CD4 count of 34. R. equi is genetically related to nocardia. Both belong to the Actinomycetales. It is a cause of pneumonia in severe immunosuppression, and almost half of patients have exposure to horses. it is highly lethal. In this case, despite treatment with vancomycin and rifampicin, the patient died. The arrow points to an area of probable cavitation. This video is part of a series on opportunistic diseases in HIV/AIDS. I'd be grateful for any feedback that you might have. If you are interested, please subscribe.